mean,
Not
right?
trying to correct the alignment at all, just trying to deal with the current problem, which is the gradually progressing myelopathy. And if it's truly a motion thing that it only happens in flexion, well, fuse her in neutral, and because we know from her MRI that she's not compressed in neutral.
Yeah. So you think about doing posterior fusion only? No.
I'm thinking about it. Yeah.
Yeah.
I'm wondering, and again, that's part of the reason I'd want the flexion, see what the flexion extension MRI is really showing us, because I
Yeah.
think that would make me decide, sort of would let me decide whether I think this is something that we just need the stability, or whether
Yeah.
this is truly something that we do need to get the alignment corrected.
Yeah.
If
But
your
you
if
said,
your dynamic MRI shows you no compression at all of the spinal cord, would that change your decision making?
Yeah, I wouldn't do anything
Okay.
if unless I'm if she's got progressive myelopathy but she doesn't have compression, I don't know why she's progressing myelopathically, and I don't know an operation that fixes that. So no,
Got
there
it.
would be
Okay.
no surgery unless the flexion MRI, and I'm going to assume just by the look of it, it's the flexion one that is going to show something. But yeah, unless the flexion MRI showed something, I wouldn't be doing surgery at all.
Okay. Makes
yeah.
sense.
So that's what that's the thing I was telling about late postoperative myelopathy or
Yeah.
myomyelitis, that we don't really have the reason or don't know why. But even on flexion extender, if the facets are fused, I wonder why the flexion extension MRI should show anything else, because if it's fused, it's
What you
not
get is
moving.
you get a relative degree of tethering.
Yeah.
And
Yeah.
so when you flex forward, because the cord is relatively tethered, it gets pressed against the ventral bodies. And sometimes you'll even see a post-laminectomy membrane there,
Yeah.
that comes in from the back. And so that's I've seen that a few times, and that's sort of that's conceptually what I'm thinking here. If this is truly a progressive myelopathy, if this is a stable myelopathy and she just has this deformity, if that neurologic exam is what her neurologic exam has been for the last 10 years, again, I wouldn't do anything but follow her. The,
Yeah,
the, the
but that was
decision
I
to
was
treat.
going to ask that. Would you open the dura when you are doing the surgery?
If she only has compression and flexion, no, I wouldn't.
Yeah.
Why
Dura
I
was
was
put there
asking
to
was
keep
that
me out of trouble.
Yeah.
because we really don't know the cause of myelopathy here, and I have operated two patients in last 2 years. One was cervical, one was thoracic, and both had tethering of the cord posteriorly to the dura, which was not really very clearly seen on the MRI. But yes, the cord had slightly shifted backward. We just detethered it, and it was densely stuck to the dura, and we presume
I
that
mean,
that was the cause of
yeah.
myelopathy.
And again, that would be something to think about as a cause if the flexion extension MRI didn't show compression.
Yeah, the problem is that when you look, yeah, I understand what you're saying, but the problem is that when you are seeing a patient who is developing a progressive myelopathy and we are doing nothing, it's like we know the result, so it will still be progressing. But yeah, I agree that you should not operate just to say, because just by doing an operation which you don't feel the reason, it will not improve the clinical picture. Yeah.
Yeah.
I got it.
What we don't know in this case, and unfortunately, I don't think the person did the case. If you're on, please notify in the chat. But if this is a progressive myelopathy, I don't at this point in time know why it's progressing.
Yeah. Yeah, that's another comment from one of our participants, Michael Azeget, who said what we just said about checking the thoracic spine because of the
No, absolutely, you need to check the thoracic because of that sensory level, but it doesn't explain that she's also got well, mind you, the upper extremity symptoms, the upper extremity findings she had could just be holdover from her residual defect from her AVM, which we just don't know what the neurologic progression is here.
Yeah. Yeah.
Okay.
Sure. Okay.
All right. Shall we move on to the next case? And I'll stop
Yeah.
sharing.
Okay. Thank you, Doug. Should you go, Sandeep?
Yeah, okay, I'll do that.
Hi, Salman. Are you there?
Oh, Salman messaged me that he had to go for an emergency surgery. I'm sorry that I could not log in before. I don't know why, but it was not allowing me to log in. So, so I could not tell you before.
Okay.
So can you see my screen?
Not yet.
Yet.
Okay, so just give me a moment. So because I don't know why my laptop was not allowing me to log in, so I'm just logging in from my son's laptop right now. And I'm used to Apple, and this is Windows, so I'm just checking it. Where is the mic on? Okay. Okay, can you see it?
Yes.
Yeah. Coming now.
Oh, perfect. So this case was sent by Dr. Manoj Agrawal, who is a neurosurgeon at RML Hospital, which is one of the big government hospitals in New Delhi. So I'll just go to the case. So patient is a 33-year-old male patient who
Go
presented
for
with
full screen,
backache.
Sandeep? Full screen?
Pardon?
It's not
Pardon?
full screen. It's not, if you can
Where-
put in full screen.
So it is on full screen on my laptop.
Okay.
Okay.
Go back to presenter view or whatever there.
Yeah.
Now
Yeah, I
we can
did
see the
that.
history here now.
Is it full screen now?
No, it's not. You won't be. Sometimes it glitches this way, and if you just leave it in the initial layout,
Okay.
you can then just progress through the slides anyway.
You're probably
Okay,
just
so
sharing. You're probably just sharing the wrong view when you're sharing it with everyone. You're sharing the wrong screen.
Okay. Anyway, we can see the history here now.
Okay, that's perfect. Then doesn't matter whether you are seeing it on the full screen or not.
No.
So patient had a low back pain with radiation to both lower limbs for 4 to 5 years. And he had difficulty in walking for last 2 years. There was imbalance while walking and he had frequent falls. He was unable to void urine and he had history of an indwelling catheter in the past. It doesn't mention whether the patient still has urinary difficulty because it just says that he had difficulty in the past and he has no known other comorbidities. And so his upper limb power was normal, while in lower limbs from hip to ankle, it was 4/5 bilaterally symmetrical. And deep tendon jerks were normal in the upper limbs and they were absent in both knee and ankle, and plantars or flexors. He had sensory loss only in S1 dermatome on the right side, and perianal sensation was present and the anal zone was normal. So he had a 4 to 5 years of history and with motor weakness for last 2 years and some sensory loss only in S1 dermatome on the one side. And his deep tendon jerks were absent, with plantars being flexors. Now this was the X-ray, and the X-ray shows some destruction of the bone from L4 to mid-sacrum or up to S3. You can see here. So then a CT scan showed an expansile lesion here, which has destroyed a lot of bone. And so that's it. This is only, and there's another CT image in axial view, and you can see here the amount of lesion here, which is expanded into the bone. And this is the MRI. And I think there is another MRI. And so there is a large lesion here filling the lumbosacral canal. In the axial view, you can, I don't think that was a contrast MRI, but this one is a contrast MRI. You can see that there is enhancement of, it is contrast enhancing. Now, the question for you is, what is this tumor? What is the differential diagnosis for this tumor? Doug?
The first, if you go back to the CT,
Uh-huh.
um,
Okay.
yeah, the axials, that's it. So it's got a sclerotic rim to it,
Yeah.
which automatically puts it into the more benign, maybe benign aggressive. So we're not looking at malignancy likely here. And that goes with the gradual progression and things like that. This could be a large nerve sheath tumor. It could be an unusual form, an unusual presentation of a chordoma, because usually though the chordomas do not have they're usually more aggressive. They usually have a more infiltrating border to them. So I think sort of first, second, and third on my list is some form of nerve sheath tumor.
Yeah, I actually agree with you here because you can see the sclerotic margin. The bone is not that destroyed the way the chordomas destroy the bones, and the history is of 5 years. It is very
Mhm.
slowly progressing. So I think you're right.
Yeah.
Now, Paulo, do you have any other thoughts?
No, yeah, I agree. I think that this kind of scalloping of the vertebral bodies, as was said, is suggestive of a slowly growing big nerve sheath tumor.
I
Of
mean,
course, there are differential diagnoses, but still,
it also to me it seems as though it probably originated in the canal, because the other things you could think of are things like giant cell tumor and variants of that. Eosinophilic granuloma is another possibility. But again, those usually tend to arise in the bone, and whereas this, particularly on the MRI, looks as though it's arisen in the canal and probably in the dura.
yeah, the same is true
Would you
for
keep
other
ependymoma
like
as a
the
differential?
neural.
Sorry, Sandy?
Yeah, would you keep ependymoma as a differential?
Yeah.
Yeah,
Because
and of course,
ependymomas can
the
also
other
grow in
thing
the
is
canal.
like aneurysmal bone cyst as well could be a differential diagnosis, but I would say it could be quite weird because it looks like to start in the canal and not in the bone.
See, if you see here in the contrast MRI, it is homogeneously enhancing. There are no fluid levels as you would see in aneurysmal bone cyst.
Yeah.
And so it looks more like a benign nerve sheath tumor. And I would personally keep ependymoma as the second diagnosis because they also arise from the canal and sometimes they are very slow growing and then can present in the same way. So no further treatment is mentioned. So what would you do here?
Well, I think the first thing is we need tissue. We need a biopsy.
Yeah. So would you biopsy it first and then progress for surgery depending on the biopsy, or you would straight away take him up for surgery?
I would biopsy. I just always, he's not, he's not progressing rapidly. There's no urgency to do something. I'd rather have all the information I have before I can get before I tailor my plan. So I would do a biopsy first. Have a whole bunch of people who are really good at looking at these things, make sure that they've all agree on the diagnosis, what the biopsy is, and then I'd plan the treatment from there.
Paulo, any thoughts?
Yeah, for intradural tumors, we usually don't take biopsies because no matter what this is, this tumor is causing progressive neurology, so he needs to be removed, and I think that the pathology wouldn't change the approach. So we tend to biopsy almost every extradural tumors, but not intradural ones. Yeah, we have some comments there as well, Sandeep, if you want to go over that. In the chat, there are some questions about spinal paraganglioma, for instance.
Spinal paragangliomas, they look different. Let me open the chat box.
Okay.
So here, Doug, I tend to agree with Paulo because this is an intradural tumor. It is causing symptoms. We have to remove the tumor, and whatever the pathology is, but I don't think that is going to change our approach as such. Would you treat it differently between whether it is ependymoma or a neurofibroma or something else?
No, I'm not treating it any differently because I'm not treating it. Remember, I'm a poor dumb orthopedic surgeon. Dura was put there to keep me out of trouble. It's your problem.
Sandeep, there's a comment from Dr. Denis Ivliev saying about, I guess, two-step radiotherapy. You want to comment on that?
Let me just read the comment.
The last comment.
It's like two-step radiotherapy. See, I would think that firstly, we have to operate the patient, establish the diagnosis, and only then we decide about radiotherapy. Most likely, this patient will end up with radiotherapy, whatever the pathology is. And so now, what kind of approach in surgery would you take? Would you like to do a radical decompression? Would you use neuromonitoring? What will you do during surgery?
Yeah, for me, it's really a case where in my hands, neuromonitoring makes a lot of difference because of the, well, if this is a benign tumor, ideally it should be removed completely, but sometimes this is not possible because of a lot of nerve roots are destroyed, and that's where the decision about any kind of postoperative treatment comes. So. If neuromonitoring allows me to do that, I will try to remove it completely. If not, I will stop when I have significant changes in the MEPs.
Mm-hmm. Okay. And then what about post-operative treatment? Would you give radiation to it?
I probably wouldn't. If it's a schwannoma, I rather radiotherapy is not that effective. Even radiosurgery, this is very big, a very big tumor. So depending on the extent of the resection, but on top of that, these are really slow-growing tumors. So if I can get either a complete or a significant resection of the tumor, I would follow up. And some of these tumors really don't grow significantly. I know the patient is 39 or something like that. So
33. 33.
33. So the likelihood for progression is high, but still you can always wait and see. You can always have a second look and try to remove more tumor in the future. So I try to avoid radiation in benign tumors.
Well, suppose if you are able to remove it completely, then I don't think there is any question of radiation.
Yeah.
But for example, if you remove, say, 70%, 60%, 80%, the chance of recurrence would be very high, right? He's a young guy, he has to live for long, and the recurrence rates would be high. When you could not remove it in the first surgery, I think in second surgery, it would be even more challenging. There will be a lot of scar, there will be no normal tissue planes. It will become even more challenging. So I would prefer to give radiation right up front. And normally in benign tumors, I don't give it immediately. I just let them, all the nerves recover. I wait for a couple of months, 2-3 months, and then I give radiation.
Yeah. Yeah. Again, it depends. It depends also on the pathology. But for benign, I usually, yeah. It also depends on how huge is the resection. The other thing in this tumor is that the cases I have operate with this kind of, let's say, giant nerve sheath tumors is that those patients have no dura at all. When you open the canal, everything looks like arachnoid or fibro. Yes. Yeah, so it's really very difficult to reconstruct the dura, at least in my hands, and basically these patients end up with grafts and some dural, some lumbar drain for some days, trying to have it to have it less pressure there to try to reconstruct it.
So what do you think about the risk of converting it into a malignant tumor after radiation?
Yeah, that's the reason why I don't do radiation in benign tumors unless they are growing fast, and even so, as I was saying, what I do in benign tumors is that I try to remove as much as possible, and then follow up and see if they progress fast, let's say in 1 or 2 years. I would consider radiation, but if they are slowly progressive, I try to redo surgery and remove more and leave radiotherapy and postpone as much as possible.
Mm-hmm.
And what about maybe another question is about the need for reconstruction or spinal stabilization?
Well, right now he doesn't seem to be unstable as such, but if at all, then he'll require a lumbopelvic fixation because there is nothing else left.
Yeah, yeah.
These slow-growing benign tumors, though, you know, it always amazes me the body's ability to adjust and bear the load. I mean, this guy's having some back ache. He hasn't had any pathologic fracturing, so he isn't currently unstable.
Yeah.
And that sclerotic rim actually has really good gives really good support. You know, it's how much reconstruction you really need to do is an interesting question, because you might be able to just, you know, this would be one where I would be thinking I may not instrument him, but I might throw a bunch of bone graft in there.
Yeah.
Yeah, my another worry with reconstruction would be when he definitely doesn't need it right now, I would avoid it, because suppose if he requires radiation now or in future, that implant will always interfere with the radiation. So I would try to avoid it as much as possible.
Oh, you could use carbon fiber implants.
Yeah, it's not available everywhere, and they're horribly expensive.
They're incredibly expensive, and
Yeah.
they do have a fatigue life. I would never use a carbon fiber implant in this situation, because this guy's going to be, you know, carbon fiber implants are for people with short life expectancies.
Yeah, I agree. And the other thing, I completely agree with Doug. It really surprises me that some of these tumors that you look at the vertebral body and it seems that there is nothing there, but still those patients have no stability at all. Of course, that part of the load bearing capacity is given by the tumor itself because of the tumor mass. And since if you are resecting, you will lose this part. But at the end, this will be replaced by any kind of, I don't know, some kind of fibrous tissue or whatsoever. So I also agree that you always have the option of to go back if they develop any kind of instability instead of going from the first time. Yeah, this is quite extreme. This case is quite extreme because particularly I think it's L5 and that's one. It doesn't look there is nothing left, but yeah, but still.
Okay, shall we move on to the last case?
Yeah. Okay, thank you. I don't know if Nikolai was able to join already. Otherwise, I can. Okay. So if you can share, Sandeep. I think Nikolai is not there yet, right? Okay, so I'll put case 4. And if Nikolai steps in the meantime, I think he can still present his case. I think you can see it now, right?
Oh, did we not do case 3, the SMX Bondi?
Sorry?
There was case 3.
That one was to be presented, and Nikolai just texted me like 10 minutes ago saying that he was able to join in 10 minutes. So that's why I was going to case 4.
Yeah, sure.
Then we go back. Okay. So this case has been presented or submitted by Dr. Rayan Thiawol and Dr. Jeong-Soo Han from Ansan in South Korea. And thank you for submitting the case. Why? You can see the slides, right? Okay. So it's 80 years, so it's a very young patient, 88-year-old, posterior neck pain on the right side for 1 year, no major comorbidities, and it looks like to be a right side posterior neck and occipital area pain that started a year ago, did not improve with conservative treatment at local hospital, and she had an electric tingling sensation when she bent her neck forward or backward. The patient was very old, pregabalin was prescribed first, but the symptoms did not improve. A greater occipital nerve block was planned. After 1 month, the symptoms improved. Probably it worsened, so pregabalin was prescribed again, and the patient was followed up. 2 months later, she had difficulty using the chopsticks and spoons during to motor weakness. So it was pain was relieved by the nerve block for about 2 months, and then she started developing motor weakness and difficulty, particularly washing her hair. So this is the neurological examination. So it's a grade 4+ in the lower extremities, and also and on the left side of the upper extremities, and the grade 3 in the right side, or right side, I presume. So there is also numbness, Hoffman signs, so hyperreflexia and gait disturbance. Okay, so this is the radiological findings, where we can see what looks like a calcified panels in behind C2. Presume this is I think this is a CT angel, because the vertebral arteries look to have contrast. No instability on flexion extension, as far as we can see here. This is the MRI. So we can really see the compression of the spinal cord there, and focal atrophy and signal change at the level of C1. And yeah, the questions are, what's the best treatment? Is laminectomy necessary or not? And I wonder when retroodontoid pseudotumor will disappear. Sandeep, do you want to start?
Yeah, so this looks like osteoarthritis, and so she has developed some pseudotumor there. So I think the ultimate treatment would be C1, C2 fixation, but perhaps because the symptoms are significant in there, you can see cord changes also. So I will do a C1 laminectomy also.
And C1, C2 fusion, right?
And C1, C2 fusion. So in rheumatoid arthritis, it works pretty well.
Doug?
Yeah, I'm. There's the sort of two parts. You know, I know that the pseudotumor is due to motion, and I know that if I stabilize her, she will improve. But it's hard to look at that and think of how quickly and easily I could take the C1 lamina off.
Yeah.
And in an 88-year-old, she's going to fuse. So, you know, conceptually, I know that all she really needs is stabilization, but I'd sleep better if I took the C1 lamina off.
Yeah, I think it's more, what do you lose doing that, by doing that, right?
A higher pseudarthrosis rate.
If you take off the
C1 lamina, yeah, unless you're going to go in and decorticate the facets and fuse, you know, pack bone into the C1, C2 facets. But again, it's very difficult. If this was a 40-year-old,
Yeah.
where I think pseudarthrosis is really a risk. In an 88-year-old, I don't think pseudarthrosis is really a risk.
Yeah. So you wouldn't open the joint, right?
I wouldn't open the joints. I've tried that, and I guess if you got basilar invagination or something like that, where you want to get that height back, yes. But I just can't stand the bleeding every time I go there.
Yeah. What about you, Sandeep?
Pardon?
About going inside the joint.
I couldn't hear you. What did you say?
Sorry, about going to inside the joint to decorticate and go open the joint and put bone inside and decorticate it.
Yes. So typically speaking, I've never done an 88-year-old lady, but every time when we do C1, C2 fixation, we do that typically in all the patients.
Even in older patients, yeah. I tend to think of dogs. So if it's something I need to distract, I go inside the joint and try to pack some bone there. But I wouldn't. But to be honest, in the almost 90-year-old lady, I think pseudarthrosis is not that an issue, and it's faster if I just put the screws there. But yeah, I agree that from orthodox, let's say, point of view, you need to put bone either between the C1 and C2 posterior arch or inside the joint. There any other comment? I cannot see them. I cannot see them.
I'm curious if anyone does
I lost you there, Andrew.
Yeah.
articular screws. We do them routinely here, but I've heard.
You mean transarticular screws?
Transarticular screws.
Yeah. Well, I haven't done transarticular screws for, well, maybe 20 years or so, but yeah. Just when the segmental fixation became more popular, I stopped doing that. And on top of that, it's like the transarticular screws on themselves are not stable in flexion extension. So you still need a posterior tension band. So you should either need a claw or something in C1 or a wiring, which at the end is also increasing the time of surgery.
And if you're going to do that, you can't take off the C1 lamina.
Yeah, of course. Yeah, of course.
I'm not as pessimistic about transarticular screws as you are, Paolo. I think that I think they are a viable option. For me, it's just the change to segmental fixation just takes a lot of the fiddling of transarticular screws out of the equation. Making sure you've got that perfect trajectory, and I just found transarticular screws annoying, and that's why when I started doing the C1 C2 segmental fusion, I basically stopped.
Yeah. Okay, so any other comments regarding this? So I don't know if there was any other comments since no. Okay. So maybe we put quickly the other case here. Okay, let me try to share the other case, which is this one. Nikolai, okay, not this one.
Yeah, that's the case, yeah.
Same case, sorry. So, not.
No, that's the case.
No, that's this one. Okay.
Yeah.
Okay. So yeah, presentation is quite fast. So this is from Dr. Denis Ivliev in Smolensk. So males 42, at least 10 years of low back pain, and currently left side radicular leg pain as well. So quite clear. On neurological examination, low back pain VAS of 4 to 5, less range of motion in the lumbar spine, disability comes because of pain, decreased quality of life. He has a BMI of 35, and on radiological imaging, he has grade 2 isthmic spondylolisthesis with this, yeah. And so the questions for the board is posterior only, anterior and posterior, for L4 to S1 or L5 to S1, or combination of posterior and anterior approaches, cons and pros. Doug, do you want to start with?
Can you go back to the images, Paulo? Again. Yeah. Okay.
Reality of this case is anything you do that decompresses the nerve and stabilizes it is going to work.
Yeah.
And so a lot of it's going to be personal preference. But, you know, this is one where, you know, you could argue for instrumented fusion, uninstrumented fusion, interbody, anterior, posterior. You know, anterior alone, I think we can rule out because you don't have an intact posterior tension band. But beyond that, anything is probably going to work. And nobody's ever shown, other than some limited studies, that any one is that much better than any other. My own personal preference for these, if I think that I can do it, is to do this as an anterior with percutaneous screws posteriorly, just the one level. The factors that would lead me for and against it, there are BMI 35 patients, and then there are BMI 35 patients. Some people have a BMI 35 and they carry it all in their abdomen, and the skin to spine distance is like 20 centimeters. And I'm not going to do, particularly looking here, his vasculature is he's got a little bit of a low bifurcation, probably because of the segmental, the segmentation abnormality that looks like he has. So his vascular anatomy is a little strange. If he was relatively slender, I'd do him anteriorly with posterior percutaneous. If he has most of his fat is up front, I'd do him posteriorly as a TLIF.
Okay, Sandeep?
Yeah, I would personally do a posterior percutaneous TLIF.
And the rationale for that? Why posterior? Why not anteriorly?
There are multiple reasons for that. If I do, and see, one of the big reasons is the cost involved. When that will require two procedures. If I'm doing percutaneously post TLIF, I'm using the same procedure, same approach. I'm just putting in a cage from there, right? And those cages are relatively cheaper as compared to the LF cages. And that will require a bigger surgery. The cost will increase. So the time of surgery will increase. So I just prefer to do it posteriorly.
Yeah. Yeah, I tend to, well, on those patients, I tend to think and to put into the equation different situations. One is how is the global alignment? So if I really need to get a lower doses in L5 S1, I tend to go anteriorly. If loss of low doses is significant. So, and if it's aisthmic, aisthmic lysis, I do anterior ALIF and then percutaneous screws, as Doug was saying, to restore the posterior tension band. If not, I tend more to go posteriorly. And the other thing is also about the vascular anatomy, because we just have a cut here, but at least in my hands, this would be very difficult to go anteriorly, not because of the arteries, but because of the veins. So the bifurcations of the veins are just in front of the disc, or it looks like. So I wonder it would be very difficult to put a cage and to try to sneak a cage in between those vessels. So yeah, putting these all together, my preference definitely will be for a posterior.
Yeah, this anatomically in the vascular anatomy, this is actually more equivalent to an L4-5 than it is to a 5-1. So you would actually do this from taking the vessels from left to right. and running them across. And yeah, I'd want to see a whole bunch more cuts. And again, it depends entirely. My preference is for isthmics is to always go anterior posterior. I don't actually use cages. I use that femoral ring allograft.
Yeah.
Because femoral but yeah, this one I'd need to see the patient's what he looked like and a few more cuts to decide whether to do do it anteriorly. But as I said, to start it all off with, I don't think you can lose with this one. I think that whatever you do, the patient's probably going to do pretty well.
Yeah, I would love to have femoral rings allografts, but unfortunately we don't. So this is the case solution that was sent by the submitter of the case. So he did the posterior only, and even the restoration of lordosis and reduction.
Really well done.
Good. Yeah, very good.
Looks pretty
Very
good.
good result.
Yeah, it looks like an anterior approach almost, right?
It's got almost the lordosis of an anterior. Yep, but you can see the cage there front. No, that looks really good.
Yeah, that was a very good, at least radiological outcome.
Yeah.
Okay.
And then when you were mentioning femoral allografts, the cost of that would be more than the cost of total surgery and the implants in my area.
Really?
So it doesn't really make sense to use those things for us.
Okay.
They are not even available, but yeah, I'm saying if they were available, the cost would have been more than the cost of the total surgery.
Because it's $600, $600 US dollars.
So when I was in US many years ago, so at that time they were much more expensive. So
Yeah,
I just remember that cost.
A pre-machined femoral ring allograft that I use is $600.
So this is the only thing that is cheap in the US, right?
Yeah, pretty much.
Okay. Okay.
Yeah, but
so
$600 is not bad. So
yeah.
I didn't know that.
Good. So thank you all for joining. So this is the end. So this is the as you know, we're trying to do these case presentations and discussion once a month in the third Sunday of the month. So next one will be out October 21st. No, 22nd. Yeah. So we will send all the invitations and announcements again. So please submit your cases, and it's very nice to have you there. Thank you.
Okay, thanks. Have a good day.
Bye-bye.
Okay.
Thank you.
Thank you.
Bye-bye.